That was a great talk by Dr. Koiken. We're gonna kind of transition into bone. I know that we've already mentioned that liver is way more common, and this will be a little bit more nebulous in the sense that it's not going to be as common, but it's kind of interesting to talk about also what kind of interventional treatments we can do for the bone. So, it's actually to have bone metastases when all cancers are considered is that it's relatively common. And when you have cancer of the bone, not only do you have a tumor in the bone, but you also have now a bone which is providing structural support to your body, which is now weakened, and that can also lead to pain from fracture and things like that. So the interesting thing, or the good thing, is that interventional radiologists can treat both the cancer and also the fracture in patients who otherwise couldn't have surgery or don't prefer to have surgery. So the most common procedures that we do in the bone are called vertebroplasties or kyphoplasties. And what both of those procedures are, they're essentially the same type of procedure, is that when a tumor involves the spine, the bone in your spine can fracture, and you get something called a compression fracture. And so that can actually lead to a loss of height, or what we call a kyphosis, like people leaning over. And so what we can do is we can actually place needles, again, percutaneously or through the skin using X-ray guidance, and place these needles into the bone and inject cement, and also potentially burn the tumor as well. And again, I'm talking about this for cancer, but we also do this for patients who have just your run-of-the-mill or osteoporotic fractures. So here's an example of a compression fracture. The yellow arrows highlight how that fracture is kind of wedged or compressed, whereas the other vertebral bodies above it and below it are normal. They look like just kind of like picture frames. And so using this exact technology, which is what we call fluoroscopy or X-ray, we guide a single needle into there. Sometimes we can put two as well if we want to. And there's the needle in there. And through that needle or cannula, we can inject cement or polymethyl methacrylate. And what that does is that will basically stabilize the fracture. We can also put in a balloon, and what that does is kind of restore the height of the fracture as well. Here's another example. This is a patient actually that has cancer at 3 different levels, and you can see here we put 2 needles in, and the decision to use 1 or 2 needles again depends on the type of device that you have. But we put in balloons, and then we inject cement as well to kind of stabilize that fracture. And this is what it looks like afterwards. So it looks like that dense, very dense cement that's in there, and we're able to stabilize the fracture to the point where that actually bone becomes stronger than the ones above it and below it, and so we get really good results. Now we're moving into an even more exciting era where we're actually able to, again, percutaneously or through the skin, place implants. And so this is anybody that's ever had to fix a tire in a car or has seen somebody fixing a tire in a car, you see a tire jack, right? This is called a spine jack. So we're able to place what we call a spine jack, and what that does is, again, it has about 1,000 newtons of force, that actually able to lift the height of the fracture up, and we leave it, and then we take out the needle. And again, minimally invasive. There's just a Band-Aid at the end, and you go home at the end of the same day. I'm also just going to kind of transition into talking about bone tumor treatments. So this is more just, we're talking about cement and just fixing fractures, but we can also specifically kill the tumor in there as well. And again, it's that concept of ablation is going to be the most common thing, where we place the needle in there and we're going to either burn or freeze it. And so here's a patient. This is actually a benign tumor, but just wanted to show it because it's kind of a cool example of a tumor here in the spine. And this is high up in your cervical spine, so kind of in the neck, kind of a pretty delicate area. And we started advancing this needle, but again, the beauty of image guidance is we can know where we're going by injecting dye, and we actually see there's an artery there. So we said, okay, well, we're not going to put a needle directly through an artery. Let's go a different way. And we're able to come from the back, and then we're able to place this small needle in there and burn that tumor away. So everything I've talked about has been in the spine, but we actually can also do all these things outside of the spine as well, and we call that cementoplasty or osteoplasty. And again, the purpose of this is to inject cement to stabilize the fracture, but also relieve the pain. So it kills the tumor partially, and then it also stabilizes the fracture. So this is a patient that had a hip, actually had a tumor invading their hip. You can, oops. Sorry. There's a tumor here in the hip, and what we did was we placed 2 probes, and they're called, and again, depending on what technology we're using, we're going to freeze this tumor, so it's called cryoablation, and that's actually the ice ball. You can see that yellow arrow outlining the ice ball. So that we killed the tumor, and now we've created this cavity of basically a void or absence of bone that was normally there, and then we just fill that up with cement. Again, Band-Aids at the end and all that sort of stuff. So same type of procedure. Another hip metastases. Again, we like to use cryoablation outside of the spine a lot. And again, you see the ice ball, and then we fill it with cement as well. So I'm just going to finish by talking about the next frontier, which is really exciting. We've sort of started to do some of this at the University of Chicago. We're working very closely with our orthopedic surgeons on this. And what basically happens is, a lot of times a lot of patients that have these type of bone metastases, they're pretty advanced in their stage of their cancer, meaning they're not the most ideal operative candidates. And where a lot of these bone metastases sometimes go are in really bad places for surgery. And commonly that would be in the pelvis area, because the pelvis is a kind of a tough area to kind of work and operate in. But you can imagine having a fracture or something in that area could be very debilitating to patients. And so what we're working on doing now is we're actually able to, again, using X-ray guidance, actually stabilize or pin these fractures with screws. And the reason we do that is because you can imagine, again, we talked about how a tumor invading a bone causes pain from just the tumor itself, but also from the fracture or the instability that it creates. And cement is nice, but cement doesn't help with torsional forces. It helps with only compression forces. So to prevent a torsional force, you need to fixate that fracture with a screw. And so what we're trying to do, again, is try to reduce that morbidity. And this is just kind of a cartoon graphic of what we potentially now can do using X-ray guidance, is we can place these screws through the bones of the pelvis. And you can imagine, see how the kind of complex anatomy is, very 3D, three-dimensional. But we can put them through multiple bones in the pelvis. And again, what we do is a combination of cement, screwing, and also ablation as well. So simple example here, just place a needle through it, place some cement to fix the screw in there, and then leave a screw behind. Here's a kind of a real-life example of what I just showed you. Again, cement there, and then screws kind of fixing the fracture in 2 different planes there. This is a 3-dimensional kind of image of that. So in conclusion, interventional radiologists can help patients with cancer involving the bones by treating both the cancer and the underlying fracture that it may cause. A wide variety of minimally invasive procedures with new options are upcoming. And again, the best part of all of this is it's a lot of, just like Dr. Koigan said, with a lot of our treatments, it doesn't compete with other things. It's a very synergistic thing. So this doesn't take any other options off the table. Thank you.
Thank you for having me. So as a neurosurgeon, I treat patients that have tumors along the brain and spine that are sometimes benign and sometimes cancerous. And I would say a very small proportion of my patients have neuroendocrine tumors, but we do see them. So 6 to 12% of patients with neuroendocrine tumors report bone metastasis, and the spine is just one area which these mets can go to. The different neuroendocrine tumors have different percentages where they go to the bone. So 25% of patients with pheochromocytomas or paragangliomas present with bone metastasis, and an even lower percentage of the other neuroendocrine tumors. But the vertebral bodies are actually the most common place where bone metastasis go to. And as physicians, we think that probably a higher percentage of patients that have neuroendocrine tumors have bone metastases that are even reported, because in autopsy studies, nearly 42% of patients have bone metastasis when they were closely examined. So even though historically neuroendocrine tumors weren't really thought to go to the bone, I think more and more we're understanding there is a fairly, it is a higher percentage. So the presentation of bone metastasis is usually with pain, and sometimes bone metastasis is just picked up in screening when your oncologist is screening for your tumor. 10% of patients present with cord compression, and I'll talk a little bit about what that would be like. 9% with pathologic fracture, some of the things that Dr. Ahmed was referring to, and 4% with hypercalcemia picked up on your lab results. So symptoms of cord compression. So this would be back pain. That's the most common symptom. And then if you have significant compression of your spinal cord, you can have numbness, weakness, and trouble with your walking or gait instability, or urinary incontinence is one of the more later stages. So when we are treating spinal metastasis, we have goals. And the goal is usually not cure, especially for neuroendocrine tumors, because this tumor is a metastatic disease, so it's not your primary site. And we talk with our patients about what are the goals. And if your presentation is with pain, then usually one of the primary goals is to treat the pain. Can we make your pain better? Of course, if you're presenting with weakness or numbness, we're talking about preserving your neurologic function, maintaining your ability to walk, maintaining your spinal stability. Like if you're presenting with kyphosis from a fracture, meaning you're leaning forward or you're leaning to the side because of stability, we're talking about how we can fix that. And we sometimes can talk about tumor control. If the rest of your disease is very, very stable from your systemic therapy, and this is the one area that's causing you a lot of trouble, we'll talk about fairly aggressive surgical options to control that tumor. So I know Dr. Ahmed talked about some of the minimally invasive options, but when I see patients, usually we're talking about surgery, but we do have some other treatment options. We also provide stereotactic radiosurgery. This is a type of focused radiation, or just general radiation therapy or conventional radiation, which can be good for pain relief, but not always for disease control. And of course, with your oncologist, you're probably also talking about your systemic control, systemic therapy, and there's always an option of not talking about surgery for the spine, but really monitoring that and treating your systemic disease. When we talk about open surgery for spinal metastasis, the most common thing we talk about is how you're doing with the rest of your cancer treatment, meaning how long, how many good weeks, good months, good years do you have? And the reason why that is so important is because the open surgical treatments for spinal metastasis can be some surgeries that they take a long time to recover from. Many of these take 4 weeks in an inpatient rehabilitation unit. So we're taking you away from your home and we're putting you in a place where you need a lot of time to recover. So let's say you're at a stage of your cancer, which is fairly advanced, and you have 2 good months left. We're probably not talking about doing a 12-hour spinal fusion operation where you're going to spend 4 to 6 weeks in an inpatient rehab. That just, for most people, doesn't make, that's not the right decision for them. So we have a very in-depth discussion about what are the goals, what has the oncologist said. Myself and the oncologist always talk before we do any type of big spinal operation. And then, of course, in terms of surgery, although our complication rates for some of these bigger procedures have gotten fairly low, we're talking in the 5% range. I mean, if you have one of those complications, it doesn't matter what the percentage is, because then you've taken even more weeks of your life and you're spending those weeks in the hospital. Like, the complications you can get from spinal operations can be infection, which you need weeks and weeks of IV antibiotics, or wound problems where you could need more operations to fix that. And so it's very important to understand what those rates are and if you're willing to take those risks to see the benefits. In terms of spinal metastasis, the surgical indications usually are if you need a tissue diagnosis. Well, this is uncommon for people with neuroendocrine tumors because usually you already have a diagnosis. Spinal tumors are not usually the first presentation. If you have a radioresistant tumor, which some neuroendocrine tumors are, in which case surgery is the only way to relieve the pressure on the spinal cord. If you have cord compression or spinal instability, in which case we have tools to help you with that, like screws and rods. I'll show you some pictures of that. If you've had radiation therapy to the spine, but you're still continuing to progress with your symptoms or having worsening numbness or weakness. If you have tumor recurrence after other sorts of treatments, or you have persistent symptomatic disease, even on your best medical therapy, and of course, intractable pain. Many times pain is because you have spinal instability, even though it's not always apparent on just one MRI or on a CT scan. Based on your history, it can be a sign of spinal instability, and we talk about that and whether open surgery is a good treatment option. One of the old criteria that we use to look for patients who are good candidates for spinal decompression procedures is called the Patchell criteria. And the criteria for this is radiographic cord compression. That means you see on an MRI that there's tumor pressing on your spinal cord. If you have a neurologic symptom like numbness or weakness or pain, okay, and this can be just back pain. If there's a single region of tumor, meaning the cord compression is just in one place, not all over the spine, because obviously that would increase your risks for surgery a lot more, and you have an estimated survival of 3 months. And that was just the criteria that this paper used, but that's kind of a guideline we use as a life expectancy guideline where we kind of say, okay, maybe that's a cutoff for surgery because then you have enough time to enjoy the benefits of surgery. And in this criteria, when people who fit that were operated on, they were able to retain their mobility or ambulation for longer. Now, one important thing to remember is that it did not make a difference in life expectancy. People were just able to walk for longer. And so that's an important thing to remember. This is not curative surgery, it's just for symptoms. So here's some case examples. This is someone you can see, this is an MRI. You can see the spinal cord is that gray structure surrounded by the white fluid, which is spinal fluid. And one of the vertebral bodies is broken, collapsed, pathologic fracture, and it's pushing on the spinal cord. And this is the type of operation we would do for that, where we put screws and rods to stabilize the spine, give the spine strength, and then remove part of the vertebral body, which is causing that compression on the spinal cord, and replace it with a titanium implant, a cage. A procedure like this takes about 6 hours or so, maybe 5 days in the hospital, usually 3 to 4 weeks of rehab. So big surgery, okay? But this gentleman was able to walk when he came in not walking. So this is another patient, a little bit different if you look here. I don't know if you can see, there is a part of the spine which is pushing back into where the spinal cord or the bottom of the spinal cord runs, but there's not as much compression. But this patient had very remarkable back pain. Every time they moved, they had pain in the back. So we offered stabilization surgery, screws and rods only. They woke up off narcotics, incredible results. So surgery does have its, time, but of course there are risks. I'm not a radiation oncologist, but I don't want to forget about radiation as a treatment option. There's conventional radiation, which we always use after surgery to help control tumor at that local site. And one of the things that there is not a lot of evidence for yet, but it is a promising treatment for patients that have radio-resistant tumors, meaning tumors that aren't very sensitive to radiation, which some neuroendocrine tumors would fall into that category, is something called stereotactic radiosurgery. And here, if the tumor is far enough away from the spinal cord, we can give very, very high doses of radiation just to the tumor itself. And this requires planning with a radiation oncologist and a neurosurgeon. And not all facilities offer that, but it is a good treatment option to remember. And so just as a conclusion, surgery, radiation, and radiosurgery are viable options for treatment. Every tumor and clinical situation is different. The choice to treat is an active one, and you always have to do what is best for you. And so you have to remember what your goals are, and remember to have trust in your team and get to know the people that are treating you, and they will get to know you and make the decisions together. Yeah, thank you.